Welcome back. We have another very exciting and informative talk for all of you. This has been a topic that a lot of our audience has requested to be talked about at the symposium. So we heard our audience feedback from last year, and we were able to get 2 experts on the topic of perinatal grief and loss. I am privileged to introduce Dr. Katherine Shear and Nicole Alston, who will be presenting on perinatal loss and grief. Dr. Katherine Shear is the Marion E. Kenworthy Professor of Psychiatry and Social Work at Columbia University and the founding director of the Center for Prolonged Grief at the School of Social Work. She is a clinical researcher who has first worked in anxiety and depression. For the past 25 years, she has focused on understanding and treating people who have experienced persistent intense grief, which is now an official diagnosis called prolonged grief disorder in ICD-11 and DSM-5. It's a great achievement. She developed and tested complicated grief therapy, prolonged grief disorder therapy, and 16-session integrated strength-based treatment that helped foster adaptation to loss and confirmed its efficacy in 3 large NIMH-funded studies. Dr. Shear is widely recognized for her work in bereavement, including both research and clinical awards from Association for Death Education and Counseling, and invited authorship of articles for UpToDate and New England Journal of Medicine. Her work includes more than 330 peer-reviewed publications. She's developed several widely used assessment instruments, a PGDT instruction manual, and an interactive online training program to help clinicians learn about the treatment. The website for Center for Prolonged Grief includes extensive information about prolonged grief, an interactive screening tool for PGD, a bank of webinars presented by international researchers, including clinically relevant topics related to bereavement and grief, and much more. You can find it at https://prolongedgrief.columbia.edu. Dr. Shear received a BS in biology with honors from University of Chicago and an MD from Tufts University Medical School. She completed residencies in internal medicine and psychiatry and a psychosomatic fellowship before beginning her clinical research career. Now I'll introduce Nicole Alston. Nicole Alston is a social worker with a particular expertise in grief. She has served the Center for Prolonged Grief at Columbia University in various capacities: community liaison, recruitment coordinator, and educational advisory consultant for 15 years. That is a depth of clinical work and experience. Outside of her work at the Center for Prolonged Grief, Ms. Alston has served as a consultant to numerous schools and organizations in the tri-state area. As a recognized subject matter expert, conference speaker, and panelist, she has appeared on various podcasts and television programs. Ms. Alston is the 2021-2022 Social Worker Health Futures Lab Fellow, a Portland State University School of Social Work project funded by the Robert W. Johnson Foundation. Her work focuses on exploring the future of grief. As an extension for her passion for supporting families after pregnancy loss, she serves on the board of directors for the International Stillbirth Alliance. Additionally, she has provided grief support to families who have experienced the death of a baby and the death of a child due to life-limiting illnesses. In 2020, she had the opportunity to draw on her diverse skill set to provide support as an associate professor for the documentary film, The Color of Care, executively produced by Oprah Winfrey and directed by Emmy-winning filmmaker Yance Ford. She holds a master's degree in social work from Columbia University and a certificate in nonprofit management from Georgetown University. It is such an honor and privilege and tremendous joy to welcome you both to our symposium, and we look forward to hearing your talk. I did want the audience to know that if they find the talk triggering or they find some contents of it triggering and evoking deep emotions and feelings, please feel free to step away and rejoin us when you're ready to do so. We look forward. Welcome, Dr. Shear and Ms. Alston.
Thank you so much, Dr. Downey. And it's a pleasure to be here to talk to you about perinatal loss and grief. And it's, of course, a pleasure to present with Nicole, who is a longstanding colleague and also a close friend. So these are my disclosures. You can look at them. Nothing really, mostly research grants and training grants that we do with the center. So I'm going to speak first for about 20 minutes about perinatal grief and loss, and tell you a little bit about prolonged grief disorder, prolonged grief and prolonged grief disorder. They're two different things, and the treatment that we developed. So this talk, our talks together are really intended to be almost like a tasting menu for everyone, because this is a huge topic, which excuse me, which I believe most people here know. And so to learn about it is going to take a while, and we can't possibly cover even all of these topics in this period of time. So as you probably know, perinatal loss is generally considered to include fetal and neonatal death, where neonatal is variously defined, but usually between a week to a month after the birth of a baby, sometimes a little longer than that. But globally, this is a huge problem. 2.5 million children died in the first month in 2020. And there are thousands of newborn deaths every day. And this is, of course, variable depending on where a child lives, but even in the most the best circumstance, there are way too many perinatal deaths. The rates of, for example, fetal and neonatal deaths in the United States are more than 4 times greater than annual deaths from cancer. And when I first read this, because I was in preparing for this talk, I said, that's a typo. That can't be. But it actually is true. I researched it deeply. It's in the CDC. It's on the CDC website, and of course, families experiencing perinatal loss are mostly deeply affected by these deaths, and yet often perinatal loss is minimized or ignored, and that's another huge problem. And what the consequence of that, one of the consequences of that is that we're seeing high levels of risk factors for prolonged grief disorder after perinatal loss. And we'll talk more about that a little later. And I just want to also draw attention to the fact that the national stillbirth rate, of course, stillbirth is one of the pieces of perinatal loss, which is in many ways especially painful. I don't know, you really can't say that the loss of any person that we love is especially more painful than another, but stillbirth is a very painful experience. And the rate of stillbirths for Black women is more than twice, as you see here, more than twice that of white women. But it's not just Black babies who are dying at this ridiculous rate. So are their mothers. And this was published just recently. This has been brought to our attention in a very dramatic way by a recent paper this July, published in JAMA, documenting the rates of maternal perinatal death. So perinatal loss, technically, if you use the definition and the dictionary definition, which is on this slide, that it's occurring in concern with or being in the period around the time of the death, should include maternal deaths as well, right? We always talk about it as the death of the baby, which is, of course, very important. but it kind of takes the focus off this very troubling rate of increasing maternal perinatal death. So, and not only do deaths occur at the time of delivery, as we know, or in connection with pregnancy in mothers, but also there are deaths by suicide in particular, which are directly related to an increased rate of suicide is directly related to perinatal death. At least in this one study, there have been a couple of studies like this. It's pretty clear that the experience of stillbirth increases the rate of suicidality, of completed suicides, actually, and definitely suicidal ideation, which we see in general. We see a lot of increased suicidality in people who have prolonged grief disorder. So we do know from lots and lots of research at this point that the death of a young person, a child, or any young person, any sudden unexpected death and preventable deaths, which many of these perinatal deaths are preventable, are well known to be the highest risk factors for post-loss mental health problems in general, but including prolonged grief disorder. So put another way, perinatal loss, including any of these kinds of losses, is certainly one of the most intensely painful experiences a person can have. And maternal health teams can definitely help families experiencing perinatal loss. And that's what Nicole's going to talk more about that through her own lived experience. But we know that few training programs address grief at all, and they don't, and few maternal health programs address perinatal loss. And that leads in turn to high rates of burnout in the staff who really need to help families deal with these very, very painful losses. That's a skill set that we all need to learn. It's something I know I didn't know before I started this work, kind of serendipitously, actually. So I want to talk to you for the rest of this time about grief and prolonged grief disorder, a little about our treatment. So there's definitions are variable. Sometimes people in the medical field, especially, sometimes think of bereavement as the sort of response to loss, but actually most grief researchers and clinicians think of it as the full body natural response to loss that changes over time, but not in predictable stages, and really never is fully completed. So it's complex, it's multifaceted. It's not only an emotion, it also has other psychological, physiological, and social aspects, and they vary over time. So essentially, people experience a wide range of different responses to the loss of someone close, and those responses can vary from day to day, they can vary from week to week, they can vary from hour to hour sometimes. But they're unique. Each grief experience we have is unique to ourselves and to each loss that we experience. Still, there are important commonalities, which is how we happen to be able to talk about this in the way that we are today. So this is another topic that we could spend the whole conference on, let alone this whole talk, which I'm not going to do. But basically, attachment theory, if you're familiar with it, can help us understand perinatal grief, because attachment explains love relationships, which of course occur across the lifespan, and attachment theory can explain those across the lifespan. And that means that what we've learned about maternal child relationships and adult relationships is similar to what occurs with maternal infant attachment. So the connection, I'm not sure where there's a nice image there, but it's gone. The connection between a pregnant woman and her developing fetus is perhaps the most profound but enigmatic of all human relationships, is what DiPietro said in a very nice paper in 2010. Because, as you know, a pregnant woman becomes more and more connected, really is forming a new love relationship with her developing fetus. And that relationship, as all new developing love relationships do, becomes very, very dominant in her mental functioning, and actually in the case of a pregnant woman, also, of course, in her physical functioning. So the baby becomes extremely important in her life, really almost from the moment of conception, but gradually growing in intensity over the course of the pregnancy. But pregnancy also initiates connections between the developing fetus and the father, a topic that has gotten recent interest in the literature. If you're interested, there are a number of papers about this now, but fathers, of course, also form close relationships and develop a love relationship with their developing fetus and their newborn infants in a different way than mothers do. And then connections with the baby are also initiated during pregnancy, even with other family members and friends. And that is something we don't yet know a lot about, but any close relationship that develops is going to produce grief when that relationship is lost. So the lived experience of perinatal loss starts with what we call acute grief, which almost always includes strong emotions, especially yearning, longing, and preoccupying thoughts, insistent preoccupying thoughts and memories, if there are memories, but thoughts about, in the case of pregnancy, it's more thoughts about the imagined future. And our memory system and our future imaginings are actually linked in our brain. So it's very similar to what happens, but of course has that difference. It has many differences also from other kinds of loss and grief. But I'm talking right now about the commonalities because those are very striking as well. There are also often spiritual and social responses to the loss of a perinatal loss, and those are often not so supportive. Actually, they can be supportive. They can be very supportive in grief that occurs later on in life, but very often with perinatal grief, they're not as supportive. And then, of course, there are physical symptoms, even more so in a grieving mother, but there are physical symptoms in any griever and grief-related behaviors. And this experience, any experience of acute grief, is so intense and so dominating that we have to protect ourselves from it. And so there's a natural kind of defensive coping that occurs, which includes the feelings on the right here, a lot of the thoughts and feelings on the right here, which are basically protective, and they are helpful in coping with this intense experience. So that's important to know if you're working with someone, because sometimes people want to sort of argue these away, but they have a purpose. And if you learn more about it, we can help you see how you can work with these. So what happens to all this love after a loved one is gone? And the answer is that at first, during acute grief, it feels, this is one of the intense, really painful feelings that accompanies the loss, is that it's a sense of deep love with nowhere to go. But as we adapt, as a mother adapts, as the family adapts to the world changed now by the loss of their newborn, or their the baby that they expected to raise, grief becomes a form that love takes. And I think Nicole will help you see that from a lived experience point of view. And it takes a form, it finds a place in our life. We don't forget, we don't stop caring that the baby died, but grief has a place in our life, and it can be a source of learning and growth and and positive movement forward in our own lives. And that happens as we learn to live in a world of absence. We learn to accept the reality, the finality of this loss, and the permanence, as I said, of grief, and a changed relationship to the baby who died. So the relationship to the living baby is one of future hope and joy, and lots and lots of hopes and dreams are attached to that baby that are now no longer attached to the baby, but there's still a relationship to that baby. And that sort of continuing relationship is very individual, and it's part of how we accept that reality, along with whatever other changes in our lives accompany this loss. And that can be quite variable, but there are always other changes as well. And so we have to do that to learn to live in the world of absence. And we also have to restore our own capacity for well-being. And we think of this in terms of researchers Edward Dietschy and Richard Ryan, who developed something called self-determination theory, which you might be familiar with or not. But basically, they have found that in order to thrive in our lives, we need to have possibilities for purpose and meaning, what they call autonomy, a sense of competence, and feelings of relatedness, which are essentially feelings of belonging and mattering in the world, and the promise of satisfying relationships. So we make these changes by changing a whole set of automatic expectations and thoughts and behaviors to fit this very changed world in which this expected baby is no longer with us. And as we do that, it helps to reduce the stress of the loss and promote growth, personal growth, and it actually happens naturally if the process doesn't get derailed. But it can get derailed. There can be blocks, there can be both internal and external impediments to the process of learning to live with the loss. And that process also takes time. It always takes time, and it always takes a variable amount of time for different people in different situations, and with different losses. But the kinds of things that can get in the way are difficulty regulating some of those defensive exclusion thoughts. If we blame ourselves or someone else, if we are caught up in imagining alternative scenarios in which this didn't have to happen, or when we have overly negative thoughts of the future, or when we have too much trouble regulating emotions. We all have trouble regulating emotions during acute grief. It's almost impossible to fully regulate emotions. But sometimes that we gradually learn how to do this, and as we learn to live with the loss, the emotions become a little easier to regulate, and sometimes that doesn't happen. Also, we need to allow ourselves respite. Periods of respite will happen naturally, usually with other people helping out, but even naturally in our own mental functioning, if we allow it. Sometimes people are not able to allow themselves that respite, so that can also be a problem. Overuse of avoidance, either experiential avoidance, which is an internal kind of avoidance, which actually is kind of like dissociating, or not really protesting and not really accepting the reality, but also avoidance behaviors, which are avoidance of reminders that the baby is gone and not coming back. And then inadequate social support can also be a big problem. Sometimes can even sort of enhance any feelings the mother might have, which is, again, very common feelings that somehow this is her fault. So when that happens, this is how we get to what we call prolonged grief disorder, which is now, as Dr. Dalmy mentioned, an official diagnosis in DSM-5-TR and also in ICD-11. And it's characterized by persistent, pervasive yearning, longing, or preoccupation with the deceased, as well as a set of accompanied by intense emotional pain or other symptoms. In the DSM, they're there are 3 of 8 of these in the ICD. There's just some examples of the kinds of accompanying symptoms you can see, and always accompanied by significant distress or impairment in important areas of functioning, and by a duration and severity of the grief that clearly exceeds social, cultural, or religious norms, which is another whole topic that's very important in the grief field, in all of our work, actually. But keeping in mind the cultural expectations and norms that the person lives with. So one thing to remember is that prolonged grief is not just prolonged, or prolonged grief disorder is not just prolonged. It's intense and pervasive to the extent that it basically sidelines almost everything else in everyday life, which it does naturally in the beginning. We all expect that in the beginning, but this is for a period far longer than the person themselves expects and the rest of their social group expects. So we know that for most people, grief is never completed, but again, the PGD differs from usual continuing grief in its intensity and its pervasiveness and its disruption of ongoing life. And this slide kind of lays that out. So if you're interested, you can kind of read through the slide. You can come back over these slides and read through it. So what I'm saying is that prolonged grief disorder is not a completely different way of grieving. Rather, because this process of learning to live with the loss is derailed, the usual evolution of grief is stalled. And this is a different condition from depression and post-traumatic stress disorder. This is an issue that sometimes comes up that we don't have time to deal with in detail right now, because I want to just briefly tell you about how we approach this, how we use the treatment, how we do this treatment. First of all, we make a basic assumption that because this is a common human experience, we have an innate capacity to adapt to this world of absence. And there are natural facilitators that help us do that help us learn to live with the loss, which include taking care of ourselves, support from other people, and finding that balance between the emotional pain and some respite from the pain, as well as balances in these other ways. Active listening is the centerpiece of any bereavement intervention, and it is the centerpiece also of the prolonged grief disorder therapy that we do, because bereaved people always need to feel heard, and we always need to listen. And that's almost always hard to do, because to listen and sit with a person who's suffering intense emotional pain evokes in all of us a desire to help them, a desire to fix that pain. And there are lots of ways that we can think of doing that with a grieving person that the grieving person isn't ready to hear. And it feels very invalidating when we try to help in that way. So what we need to do is listen. But we also, in prolonged grief disorder, we also try to guide our patients in the learning process. And we do that in 2 basic ways. We know this is because we know that learning is not just about cognitive learning. It's not just about going to a lecture or hearing someone tell you some new information. It's also an experiential process. So we have to learn also by doing, by watching, by sensing, as well as by thinking. And so when we work with people with prolonged grief disorder, we guide the learning process by working with 6 healing milestones that we believe are the way that people usually move through those 2 processes of accepting the reality of the loss and restoring their capacity for well-being. So we have these healing milestones, and we provide psychoeducation in a way that I'm not doing today, but Nicole will also kind of address in some ways. And we provide psychoeducation about each one of these milestones, and we also provide a range of psychotherapy techniques that allows experiential learning, that promotes experiential learning in each of these milestone areas. So when we do this, we've tested this treatment, which is provided in, at least in the research, it was provided in 16 sessions in a manualized treatment. And we conducted 3 NIMH-funded randomized controlled trials. All of these included a wide range of individuals. And in the first 2 studies that we did, we did have participants who experienced perinatal loss, and they had basically the same kind of outcomes here. Actually, the ones that I recall specifically, we didn't have enough to do a sub-analysis, but one of the first people I treated had a perinatal loss. This was one of the first people I treated personally myself, and she had, this was a mother who had a perinatal loss, and she had a very dramatic response to this treatment. So the takeaways I want you to have from this particular talk is that for moms and also for other family members, pregnancy is the beginning of a love affair with a child, and grief is the natural response to a loss of a loved one. We have to learn to live with reality in order to change how we experience that reality, and that will change in turn the way our grief shows up. So grief eventually becomes bittersweet, and it becomes the form love takes after someone we love dies. Learning to live with a loss can be facilitated, and it can also be derailed. And when it's derailed, it basically becomes prolonged and very impairing. So that's why we thought it should be a formal mental health diagnosis, which it now is. And we know that it needs targeted treatment and efficacious treatment interventions, not just the one that I showed you a little bit about, but there are now a handful of these studies from around the world that have been done that show very positive outcomes when prolonged grief disorder is specifically targeted. So there's a lot more to learn, as I said before, and you can learn that. You can start your learning process if you want at our website, where we offer many opportunities to deepen your understanding of prolonged grief, but also of how to use the kinds of techniques that we used in working with bereaved people generally. And we are actually about to start a perinatal grief project with the National Health Center and the National Health Service in the UK. So we are going to develop a specific perinatal loss component to our center. So if anyone who's interested in that, please do get in touch with us, and please join us as center affiliates if you're interested, or just sign up for our newsletter. You can also find these things here. You can sign up for our newsletter and just stay in touch with us. That's another thing you can do. So I'm going to turn this over now to Nicole, and it's a great pleasure, Nicole, to let you start.
Thank you so much. I appreciate it. I'm going to share my screen. So thank you so much, Dr. Shear. I really enjoyed that presentation. I've enjoyed working with you. I can't believe it's been 15 years. And thank you, Dr. Dami, for the beautiful and warm introduction. So I'm going to talk a little bit about my lived experience and my journey through perinatal grief. And you see here an image of a journey, and I appreciate all of you joining me on this journey. I want to acknowledge that there may be some in the audience who not only work in this field and also have had this experience, the lived experience, like I have. And I wanted to acknowledge those of you that work every day in the field, giving of yourselves and still kind of, again, dealing with your own grief. Thank you. This is actually a caricature of my stillborn daughter, Sky. And so for her 18th birthday, which would have been this year, I wanted to do something different to honor her. And I created been working on an animation piece. And it was based on a poem that I wrote really when I was really dealing with a lot of acute grief and struggling quite a bit emotionally a few months after her death. And the poem was entitled, I Wish. So you will see, I just kind of want to show you that you'll see some images. I've used that those images from the animation to sort of tell the story, and you'll see that throughout my presentation. And so, like many people, I had a life plan, a plan that I figured, hopefully things will kind of go along according to plan. For the most part, some of them did. And so I thought about, I wanted to, pursue education. I wanted to start a career. And I said, hopefully, maybe I'll get married. And those things happened. And with a few snafus here and there, but for the most part, things went according to plan. However, it did take some time, and these are some of the images from the animation. It did take some time to start our family. I remember experiencing a miscarriage, unexplained fertility. And so about 8 years in, we'd passed the first trimester, and things seemed like, as my physician said, like they were on autopilot. This was a textbook pregnancy. So finally, as the poem says that I wrote, our own little family. And so we're planning, we're moving along here. And again, things were going, they'd kind of gotten back on track in the journey, except that on my due date, I felt that my water broke, but it was actually, I was bleeding. And so at that point, I wasn't necessarily, you don't know what you don't know at that point. So again, being first-time parents, we didn't think it was a good sign, but we weren't sure how bad it would be. But we knew we'd call our doctor and get to the hospital as soon as possible, which is what we're doing here. However, once we arrived at the hospital, checked in, I'm in the room, I wrote that in an article that our nurse became quiet, and I had a feeling that something was really wrong. And there was something that I wrote in an article, and I wanted to share it. Only minutes after being admitted and taken to a labor and delivery room, our lives took a painful and unexpected turn. With a quick glance at the monitor, the nurse's face became pensive and grim. Immediately, my mind replayed the accumulation of events over the last 9 months, the sonograms, the doctor's visits, baby shower, planning a nursery, endless cravings, choosing a name, all of the things we anticipated would build to the happiest moment of our lives. To hear our doctor tell us that, I'm sorry, there's no heartbeat. And again, I tried to sort of bring in the characters that I remember from this moment and this experience. But everything came to a screeching halt. As I wrote, when we heard our doctor say, I'm sorry, there's no heartbeat. And suddenly, the same labor and delivery room that carried an air of hope and joyous expectation was now filled with this unyielding agony and muffled cries. And the horror, I say it was a horror because I'm like, I remember asking my doctor, well, and of course, intuitively, you have to go through labor and delivery at this point. But I asked, do I have to be induced? And he said, yes. And so the horror continued after being induced and having to endure the pain of labor and delivery. And in another article I wrote, hours later, the probability of a miracle was shattered by a macabre new reality. Our 7-pound, 1-ounce baby named Sky was born still. And she was stillborn, and it was due to placental abruption. And again, these are things that families don't prepare for. I had worked as a coordinator of bereavement services in a hospital for 5 years. I'd never met any families that said, I prepared for this moment. I had never heard of what a placental abruption was. I didn't know that there were bleeding disorders related to pregnancy. So it was a really hard shift in the journey. Talking a little bit more about our loss and what happened in the hospital, some of the helpful experiences and unhelpful experiences. I was really grateful, and I think that too, my husband's very grateful for a doctor who cared. and was very compassionate. I'll just go back to that. Very compassionate to the extent that I remember a lot of my family coming in to support us that day, and he was passing out water to family members. I mean, so it was, I really, to this day, I'm still in touch with him, and I'm really appreciative. However, there were some unhelpful experiences. There was I felt like there was a sort of a lack of communication, and I didn't know then what I know now. But I've read somewhere that they said, you know, parents will find out what wasn't offered. So it's important to offer as much as possible. I look back and I think about, I wish I would have had the opportunity to bathe Sky. You get one chance at bathing. You get one chance at dressing your baby when this has happened. So there's no do-overs. You can't go back next week and say, I wish I could do this again. I do know that 18 years is a long time, so some things have hopefully changed in some ways. I've talked to people most recently, and some unfortunately still kind of had negative experiences. I would have liked to have had more time to spend with her before leaving the hospital. And there were a lot of helpful experiences. The nurse with whom I'm still in touch, the presence that they had when they brought Sky to us. And I think sometimes too, people feel like they're being helpful and kind of taking care of the bathing and other things, but it would have been nice to have that offered. But the presence when they brought Sky to us, there was just this honor and respect. It just really filled the room. Such warmth and kindness exhibited toward us. There was a sensitivity to the possibility of different grieving styles. And they talked about that while we were in the hospital. And they also were very informative. They told me that, you know, you might have some trouble sleeping, which I'd always had kind of trouble sleeping. I was, even as a baby, my mother tells me that I was not a napper. So I was just like, okay, I mean, but I was surprised that after giving birth, like for days and weeks on end, it was really difficult to get sleep. They also explained lactation advice, and that to expect that my milk would still come in, even though Sky was not with us anymore, that the body still kind of keeps going. And that was quite traumatic. And also funeral planning. We did end up having a funeral, and I was able to, I really feel it was because of the care that I received that I had the bandwidth to write an obituary with this childlike font, with little pictures, and talking a little bit about her journey of 9 months. Some of the key takeaways here, just that showing care during all interactions. The moment that I was in the hospital with the nurse who was kind of going over my stomach at the time, it's important not to feel rushed, because in these moments, a family is saying hello and goodbye. But it's a very quick hello, and it's a long goodbye. It's not what they had planned. So it's important not to feel rushed. And really the difference here with pregnancy loss, and a number of people have written about this, that you're creating a plan for a birth and a death at the same time, which is really not what you would normally do. Helping families to process an event, as I mentioned, that they never imagined would be a possibility. People are coming in, we came in thinking, you know, again, the nursery, the showers, the endless cravings, it's building this crescendo. We're excited. This is going to be one of the best days of our lives. And so because families are not prepared, as much as possible, families need to understand every option available. Of course, understanding that it's going to be a process. They may not be able to process everything in that moment. And understanding the impact on families who make long-lasting decisions without being prepared for it. My colleague from the International Stillbirth Alliance, I love this quote. Sue Steen says, and she's the co-founder of Birth with Dignity, does a lot of work in Uganda with perinatal loss and grief. We will never have a time when there are no regrets. There will always be a few. The goal is to minimize regrets as much as we can. There's not going to be anything it's not going to be perfect, but the goal is to minimize the regrets as much as possible. And so continuing on the journey of our loss, life after Sky's funeral was a very haunting loss. I mean, coming back home to a time where you think that there's going to be a lot of laughter and joy. At the time, I was living downstairs from my sister and her partner, and they had successful pregnancies too, at the same time that my husband and I lost ours. So it was quite a challenging situation. And so there was a number of things that people said, and I think that people who've experienced this kind of loss would probably agree that they've encountered some interesting comments. It wasn't so helpful to hear that Sky, I felt that, it was kind of punitive, and I felt like I was not grieving correctly. She wouldn't want you to act like this, and you'll have twins next time, or when are you going to have another baby? Almost like these things happened on demand. Well, just be strong, Nicole, or maybe just put your sister's baby in Sky's empty crib. Maybe that should fix it. And these things, I bring this up because it compounds they're already struggling. And when you talk about prolonged grief and the support, if your people aren't supporting you at a time like this, it's really difficult. When I think about some of the people that were very supportive outside of my family, I think about my nurse, Nurse Kathy. She's given me permission to say her name. And this is one of the text messages from one of our recent communication, kind of going back and forth. And she writes, I get emotional just thinking about the loss. The losses I dealt with impacted me. She's retired now, but in a way that I will never forget. I would be honored if you would share our story. I'd love to hear you speak. And she just encourages me to continue to stay in touch. So that connection with providers that started, it was compassion. It was comfort. They provided empathy and support from healthcare providers. It's critical because it made me feel heard. And as Dr. Shear mentioned, it's important for someone who's grieving to feel heard, particularly with perinatal grief. And it really helped along my journey to have a listening ear of someone who had seen this happen before and kind of had seen people go to the other side. There are a lot of things that I wish I had known. This is what we came home to, so an empty crib. This is what I have in the animation. We'd imagine we'd come home to, seeing a baby in the crib. So hearing my sister's kids upstairs and then having this downstairs was really, really challenging. So I wanted to switch gears here and talk a little bit about moving through my grief, because we are talking about a journey. And so in terms of moving through it, as I moved through it, I realized, though, that I was still not like my cohort, the people that were pregnant around me. Everybody was getting pregnant and, having children. And that wasn't my plan. It wasn't my story anymore. And I had to learn kind of how to feel like the odd person out. That was part of accepting the reality and all the things that came along with her death. I wrote this in an article, and I have an image here of the swings. The seesaw that I'm just moving this out of the way, just one moment. On what would have been Sky's third birthday, we followed the tradition of decorating her gravesite with flowers and balloons. This year, one of the balloons slipped away. I stood there quietly, following its journey into the clouds as long as I could, smiling and crying. As on most days, I was caught on an emotional seesaw of wishing Sky were here while feeling immeasurable gratitude for the mission that her life has initiated. And that really talks a lot about what was mentioned previously about sort of that acute grief and integrated grief, that the grief was there, but it wasn't consuming me. And I was now working toward a mission and working in this field. And that is in the animation as it closes, talks about kind of how the things that we would do together. And Sky is kind of talking to me, and she's saying, she's saying, Mom, the dreams you and Daddy wished for me, I wished we could have done them too. But helping families is what I really want you to do. And she asked me to start an organization, put it in her name. And she says, there's got to be more explanation and understanding of why perinatal death and grief keeps happening. And I'm telling her that I'm so proud of you, Sky. You're right. I wholeheartedly promise you that I won't give up the fight. And then we're saying hello and goodbye. And you can see her saying goodbye. And that is really, when I think about the acceptance, accepting the reality. I don't like it, didn't ask for it, wouldn't raise my hand for it, but hello and goodbye. And I say, sadly, that's going to have to do. But this way, we can prevent so many other people from having to wish like me and you. And when I think about, what was said earlier about restoring the capacity for well-being, I began not long after her death, probably within a year, I was speaking about pregnancy loss, grief, and the birth of purpose. And it's taken me around the world. I've gone as far as Turkey and Norway, and she's been with me. And just like all of you are here with us today, I want to thank you so much for all of you and the work that you do. Thank you, El Camino. Thank you very much, Dr. Shear, for allowing me to share today.
Well, thank you for that talk, Dr. Shear and Miss Alston. It was, touched my heart. I'm sure it touched everybody's heart. We have a lot of questions, so we're going to try and see how many we can answer in the time that we have. The first question from our audience is, what are the thoughts about that there is no right way to grieve after a perinatal loss? Thoughts or comments?
Nicole, do you want to take
I'll take that, sure. I think grief is what the family needs it to be. Whatever they need it to be, whatever fits with their cultural norms, whatever fits with their idea of grief. And yeah, I would agree with that.
Okay.
Definitely.
Thank you. Thank you. Our next question is there any research on the impact of attachment between a mother and her other children when she's experiencing pregnancy loss?
Yes, I believe, yes, there is. I just was trying to think. Yes, Dr. Joanne O'Leary has done a lot of work around subsequent children, pregnancy. So yes, there is a lot of work. I can try to put that in the chat, or that would be helpful.
I guess from my perspective, it's not a lot, but I do think, so are you talking about subsequent children, Nicole? Because that's a very important topic. But also I thought the question might have also to do with, with a pregnancy loss when there are already living children in the family, and whether and a close connection with those living children. I think there is some evidence in the literature that's somewhat protective, but of course each loss is painful in and of itself. And, it's just that there's the feeling of losing your entire future isn't maybe as strong if you have other children, but then you have to also help those children, because, children also connect to unborn babies, and they have their, so that adds another layer too. So I think there still needs to be more research about that, but perhaps it's a little more protective.
Right. I've seen where, it can depend on maternal age. It can depend on, the sex of the baby. Maybe there was this long awaited, child. And there are a lot of factors. Yes.
And sometimes in my clinical work, I've also seen a lot of anxiety with subsequent pregnancies and this fear that the loss may happen at any time, and then anxious attachment in the postpartum time period.
Absolutely. Yeah.
Actually, the anxiety, I think, is well documented, and it occurs. It tends to spike. You might have seen this also, but I think it tends to spike around the time that something happened in the previous pregnancy. But interestingly, there is data on attachment, the maternal attachment to the new pregnancy, and it's kind of mixed. But I think on average, people think that it's not necessarily affected, which is interesting. That the attachment, there is a lot of anxiety, and the anxiety makes the grief and the loss more difficult, and the pregnancy anxiety makes the pregnancy more difficult, right? But the attachment, there people have hypothesized that attachment motivation is so strong that it just women find a way around the worries and still are able to connect.
Yeah, thank you for that. Our next question from the audience is, can you give examples of how young women and men process a perinatal loss, and do they have different needs than others?
So the question, do they, examples of how young women and men, and is it different?
I'm going to speculate. I think the question probably is, how do people that are younger, that's one, younger in age, than maybe general population? And the second part is there a difference between men and women in terms of processing grief and loss?
Yeah, it's hard to say that there's a one size fits all. That's one thing. There are different factors. It could, I did work with a number of younger couples, and maybe one person may have had some kind of chronic illness or something that may have made getting pregnant very difficult. Their reaction to a loss may have mirrored someone who is in advanced maternal age. So it's a little difficult to answer that question in a one size fits all. I have seen, in terms of different grieving styles, for men at times, I've noticed that sometimes the grief is maybe delayed. Someone had gotten in touch with me a number of years later and said, I was driving past a baseball field and I just started crying because I realized my son would be playing right now. So that I've seen that happen. I've seen with, moms, maybe there was the acute grief symptoms. I've seen that kind of being displayed early on. But I've seen difference with dads for sure.
Okay, great, thank you. Our next question is, what are the key points to keep in mind when you are a beginner in grief therapy, especially when seeing a mother who lost her baby?
I mean, I would say that when you're a beginner in grief therapy, the main thing to keep in mind is the two things I would say are sort of center stage. One is that you are likely to feel a lot of feelings yourself, and your feelings may be sadness yourself. You may be feeling with the bereaved person, the bereaved mother, very strongly, or you may be feeling, as I said earlier, so much like you want to help her, and it's hard to listen to her, makes you feel sad to listen to her, so you want to help a lot. And so keeping in mind that the most important thing you can do is basically active listening, empathic listening, and Nicole mentioned this strongly too, that if you don't know what else to do, you can always listen. You can always listen closely and just reflect back what someone is saying, which is a way of encouraging them, a way of both telling them that you heard what they said and also encouraging them to say more and letting them have a place to talk and not being too rushed with that. I think Nicole also mentioned that. And then learn. And then also, you know, I think when you're a new therapist, when I was learning psychotherapy myself, the chairman of the department that I was working in said that clinical experience is making the same mistake over and over again and thinking you're right. And that, I think that pertains especially to psychotherapy, because, you know, we don't always get the feedback when we haven't done something that's as helpful as it could be. So you do want to make sure that you find ways to continue your education and to continue learning. Also, this is a new research field, and so there's a lot of emerging work that will help guide you over time. So stay in touch with it too as a new grief therapist.
Mm-hmm. Great, thank you. Our next question is, what is the role of postpartum doulas with home visits with a perinatal loss patient/family?
That's a great question. I'm not sure that I would say I probably need to know a little bit more about that. I've not really worked in that space, but I would venture to say that it would be the same, that, you know, be listening.
Yeah, and I mean, I think that we know that other people in the person's life are very often kind of trying to sideline this and trying to, all those things that people in your family were telling you, Nicole, those are common things that people say. And so if you're a doula, you know, a postpartum doula visiting, I don't know a lot about that role myself. I mean, that I agree, but I do think you could be extremely helpful if you ask the person how they're doing with it, you know, not so much how they're doing, but what, you know, to talk to you about their grief and what's happening with their family and their own feelings and some of the things that, you know, are they sleeping and how are they doing emotionally, things like that.
I would say too that colleague Sue Steen, one thing that she and I talked about is that making sure that it's not a funeral yet, you know, so being there and being present and treating this like a typical pregnancy, if you will. I mean, you know, having, you know, these options, offering for holding, offering all those things, those things that honor the baby and that moment.
Thank you. Could you speak about the correlation between previous pregnancy loss and increased maternal mental health challenges for the same mother with a successful birth? I think we touched on this a little bit, but if you could expand on it. So previous pregnancy loss and then a subsequent successful birth, and we're looking at maternal mental health challenges.
After the successful birth, is that
correct?
Yes.
Correct.
Yes, I mean there's data on that situation, and there are, of course, successful births, and there are sometimes there's very often, as we talked about, anxiety during the pregnancy, and there can also be feelings of guilt sometimes, and more anxiety about forgetting the baby who died. And and Nicole, actually, you had that experience, so you could talk about it from the lived experience point of view. There's emerging data about this, but it's not from the data side. It's not something that I would say is. Certainly you would want to look for those. I think that's the main takeaway, is that you would want to look for depression and anxiety and possible PTSD. PTSD often occurs in the setting of a pregnancy loss, as you may know.
I think it's important to give people in that situation permission to feel how they're feeling, because so often, like my doctor said to me, you know, having another baby doesn't automatically put the mom or the family in the happy zone. So acknowledging that and validating and allowing people to feel how they feel. some families I've seen have struggled, and then other families, they said, they were able to, in some ways, compartmentalize the experience and move forward. So.
Great, thank you. What are some ways that healthcare providers can avoid worsening the traumatic experience of a perinatal loss? Are there procedures, medical or surgical, that women cite as being most damaging to their mental health?
Yes, I actually interviewed a number of women and did a short film on it years ago. And I remember one of the women telling me that as she was having, I believe, her fifth loss, the physician was standing over and sort of very casually saying, "Oh boy, this one's a goner." Those are things that just being very cavalier and casual about having these kinds of discussions as a mother is experiencing a death is just horrible. And that is something that continues to ring in her ears years later. Mm-hmm. So it's discussions and things like that. Another example, provider once, the mom said, please, once, I think she was having a miscarriage or something, and she said, please, I don't want to see any remnants or anything, because it's really going to upset me. And they left the baby in her room, in the sink in the room. I don't know if they forgot. So yes, there are a lot of things. I could go on and on. It's horrible.
It's unbelievable. I think we need to put the care back in the word healthcare.
Absolutely.
All right. Our next question. Many states do not have perinatal loss as a part of insurance, disability, and maternal leave benefits and programs. How can we advocate with legislative action to include this for all 50 states?
It's a good idea.
Yeah.
It's egregious that we don't have it in all 50 states, actually, right? That we have to even advocate for it. It's, yeah.
Yeah, it's a lot needs to be done in this field. Yeah. There was a question, sorry, our team is scrolling up and down, but there was a question on ethical conflicts between, correct, this is one. Inpatient settings often have ethical conflicts between services like neonatology and obstetrics with resuscitation of peri-viable infants. It places great burden on nursing when patients look to their nurse for support and advice. How do you recommend that we unite and resolve conflict about resuscitation?
This is conflicts about resuscitating a baby? Is that what we're talking about?
Yes, they are saying peri-viable infants.
Peri-viable infants. So there's infants that might or might not be viable.
And the patient's looking at the nurse and asking for support and guidance. And the teams have diverging clinical opinions. How do we unite and resolve this?
I wish that person could write what they think.
Right. And because not being actually at that, I'm more on the bereavement side, but I'm wondering too how much the families are involved in that particular discussion, and that would be my question. I wish I could explore that a little more.
Mm-hmm. Maybe exploration of families' thoughts and wishes and how they're feeling in the moment, the patient and the family, and then putting that together and presenting to the team and seeing what the team has to say. I have a question for both of you. This is kind of my personal question, but I often work with patients who have a lot of anxiety when they are pregnant subsequently after a perinatal loss. And oftentimes the discussion heads into existential issues of how do you reconcile life and death. You're pregnant, you're expecting a new life, but how do you reconcile this fact that you've also had a loss? And I just wanted your take on it.
Well, it's difficult to reconcile the two. I have said that two things can be true at the same time. That yes, it is true that there was a death, and I've said to people that the good news is that most pregnancies, they go according to plan. We make these and we intend that things will work out, but it's very difficult. I think that people have to kind of find their way, find the path forward, as you talked about, Dr. Shear, in your slides, about sort of that journey through grief. It's not just like it's not a one size fits all quick answer to it, for sure.
So in what you're saying, Dr. Dummy, is that these are women who are very anxious about the possibility that this is not going to work out again. Is that the scenario? And you can't fully reassure them. You can't, so I think you're right. That's all you can really do is say that. I think actually answering all their questions, I would say going to whatever small thing they might be worrying about. Usually, I think people worry when there's some kind of a cue that it may just be it's a pregnancy, but I mean that you can't exactly reassure them about. But if they're feeling something, as their doctor, you may want to pay a lot more attention to to give them a little more time and let them ask about specific sensations they've had, specific things they've been thinking about or feeling. They might have some specific worry, and there you might be able to provide some actual reassurance so that it doesn't get into the big broad. I mean, it's always easier to talk to someone. It's more productive to talk to someone about the specifics, and there usually are those specifics with anxiety.
Thank you. This is so helpful, and I learned a lot. Thank you. Next question. Is there a similar process that some people that have had a therapeutic abortion go through related to grief and loss?
Some do. I would say sure.
Some don't.
Yeah, it's true.
A loss of loss, yeah.
Yeah.
Are there thoughts about how to support parents who deliver multiples and lose one of the babies? How do you support them with connection, attachment to the surviving baby while grieving the loss of the child who passed away?
I remember working with families, and often the grief can be dismissed because it's like, you have other kids, so you should be okay. I mean, I actually have a colleague and friend who experienced this. She had multiples and one died, and she wrote a book about it. And it's supporting families. It can be very difficult, but I go back to validating is so important, particularly for families, because the messaging that they're receiving often is that you should be very grateful you have other children. And you grieve, you love each and every one of them.
Yeah, the should messages are there, but yeah. Next question from our audience. Can you speak to perinatal loss and prolonged grief in context of infertility, given the perpetual and repetitive loss with each cycle?
Well, so it's please. A very good question, because it's a very good question, because I think that's a really neglected area. I think that many women who are having fertility challenges and struggling with that do develop grief reactions to that, and I think it's very it's not very often recognized. I think the grief is not very often recognized, and the fact that there is grief is not recognized. And even after a couple of them, but prolonged grief in that sense, meaning that each cycle there's grief each time there's not, that fertility doesn't happen, that the baby, that conception essentially doesn't happen, and that's natural. I think that again, Nicole's point about validating, so much of what the health team can do is be aware that this is a loss for a woman, that all of these different situations are big losses, and they need to be validated, acknowledged, and validated and accepted. And that does a huge amount for the woman. You can't change it. So maybe you wouldn't want to, but it's very painful when other people are invalidating, which is what mostly happens.
And then the understanding that for them to even show up in the office to seek assistance with fertility is a whole, for most people, a grief process right there, because this is not this is not the plan I had. So understanding that for the provider's perspective, understanding that families are coming in and they're already pretty sad.
It's a loss, yeah.
And I think, holding on to the comment that you both had made earlier about holding the space, but also really for us that work in this field of healthcare, really being aware of our own emotions and feelings that are being touched and triggered is so crucial. And then remembering what we take home with us and what we bring back to our work the next day. I think that's so important. Sometimes when I work, I go see patients on the mother-baby unit here at El Camino, and I'm leaving, I often feel like I'm leaving the staff behind too. Like, you talk to the patient and you're validating and you hold the space for them, but then who holds the space for our staff? And what do, the nursing staff that go home after their shift, and how do they process what this has touched in them? Something for organizations to think about. This is a question for Ms. Alston. How long does it take to recover emotionally?
I think it's different for everyone. I've in some ways, I felt that most people, I feel like it's at least a year. I mean, because you're talking about, it's hard to put a time frame on it. I really hesitate to do that, because you're talking about a year of all the first times, the first Mother's Day, the first Father's Day, the first, what would have been the birthday, depending on if they had a premature, if they delivered early before the due date, they're grieving the day that they delivered, then what would have been the due date. There's so many, getting through that, the first holiday season of whatever that could be for the family. I would say at least a year, but it's very difficult to put a time on that.
And if I could just comment, I know that was a question for Nicole, but I think this is one of the questions, this is one of the things that's been very troubling to a lot of people, and understandably, because how long does it take to recover emotionally? I mean, in some sense, I would say you never recover emotionally. I mean, none of us would ever recover emotionally fully. It depends on what you mean by recovery. So that's something also I think to keep in mind. So it's a year in one way, like you said, almost, but I mean, some people might recover more quickly. And if that, and that there's nothing wrong with that either. I'm sure you would say, Nicole, and it may take some, whatever recovery means. I mean, we talk, we use words to communicate, but we don't always know what we mean with each other. And the other thing is that years and years after a baby dies, you can still have a lot of emotional intensity at certain moments. We have information on our website about what we call difficult times that are very common, that maybe the anniversary of the baby's birth, or their, as you were saying, Nicole, you celebrate every year, and I'm sure there's an increase in emotionality. And if it's a very stressful year in other ways, it might be a big increase in emotionality. So are you recovered, or are you not recovered emotionally? And so I would say, I don't like to use the word recovery in connection with grief in any way, because I don't think exactly you do. But with prolonged grief disorder, it is very different. People are really not able to live their lives in any kind of meaningful way. And the loss still feels like very similar to the way it does in the first weeks or months after the person died. And that's true of the perinatal loss as well.
Well, thank you for that answer. I just wanted to let the audience know I'm actually reading this. This is a beautiful book, and I know, Dr. Shear, you are an author in this. And I also realized that Sid Zizuk is in this, and he was my training director.
Ah.
I just wanted to point that out, a great resource. Thank you both for your very, very powerful and presentation that touched my heart, and I'm sure it's touched everybody. Thank you for all the questions that you answered, and we just so appreciate the great work that you both do. And thank you for being here and supporting patients and their families.
Thank you for having us.
Yes, thank you very much.
Have a good afternoon.
You too.
You too.
And thanks to everyone who's been here.